Thank you very much. Is my mic on? Can you guys hear me okay? There's the books he talked about. So I know that probably the first question that you're wondering about me is, what is that thing on your face? This is actually a scar from shaving the other day. That's exactly what you want to do when you're going to give a public presentation, is do something to your face. So if you can ignore that for a bit. So I'm going to talk about overdiagnosis, but the first thing I'm going to ask you is that, do you think you've ever been overdiagnosed for anything? And I would just let that thought sink in for a second. I would argue that all of us have been overdiagnosed, and I'm going to explain what I mean by that. And everyone watching this online, you've been overdiagnosed as well, whether you know it or not. I'll give you one example. For myself, I was having surgery a couple years ago, and of course, before you go and have surgery, they will send you for a few tests, blood tests, and an EKG, checking out your heart. And so I did this, this routine pre-operative testing, and then I get a call from my family doctor a couple weeks later, who says, "Well, you have to come in and see me." Actually, it was a couple of days later. "Come in and see me. I have to talk to you about something." So I went in to see him, and he said, "Well, your tests are fine, except there was a blip on your EKG. You might have had a heart attack." And I said, "Oh, yeah, that's probably wrong. We can ignore that." And he said, "Well, this might put you in the high-risk category. Maybe we could consider, doing something like maybe starting statins, for example." And I said, "Well, first of all, I'm not going to do any radically life-altering thing on the basis of a test, which I think is probably a false positive." He said, "Okay, well, it's your health. You do what you want." And then, again, before I went into the surgery, I had to get the test again. And I said to the technician, "Oh, by the way, last time I had one of these, they put the things all over your chest, and they are measuring your heart rhythm. Last time I had one of these, they said there was something unusual about it." And he said, "Really? Because it looks perfectly normal to me." I said, "I know it's perfectly normal, but this idea that I had a test and then I was about to be diagnosed with something which I simply didn't believe and couldn't consider to be true, how many people can really challenge tests?" And I would argue that we all need to be challenging tests. I mean, this is one of the reasons why I wrote Seeking Sickness, is because a lot of the testing, a lot of the screening tests that we're exposed to are going to be oftentimes problematic in terms of false positives, in terms of being diagnosed for something that you simply don't have. So, whenever you give a talk about anything related to drugs, pharmaceuticals, or medical screening devices, you have to declare your conflicts of interest. They're my conflicts that I am not supported by any pharmaceutical company. I have no ties to the pharmaceutical industry or the medical screening industry. I do make my living by both doing medical journalism and doing research, university-based research that's funded by the Canadian taxpayer. So, a couple of objectives here, and I want to keep this a little bit interactive towards the end. I'm very interested in hearing what you have to say, and so questions from the audience are quite welcome. So I'm going to look at, what is overdiagnosis? How can we be hurt by overdiagnosis? But this is not a bad news story. I'm going to talk about how there are people around the world who are as interested and as involved in doing something about overdiagnosis, and that's a good thing. This is a movement, and I think I'm part of the movement, and I would invite other people to consider being part of the movement of preventing overdiagnosis. Talk a little bit about choosing wisely, why that matters to you, and maybe we can have a discussion about this. So there's many ways to name this problem of overdiagnosis, and I'm going to give you a few of them. Overuse, overdiagnosis, overtesting, overtreatment, medicalization, disease mongering, iatrogenesis. Does everyone know what that means? And iatrogenesis is healthcare-induced harm. Okay, making sick from well, too much medicine. There we go. Iatrogenesis again, overutilization, false positives, misdiagnosis, overdetection, futility, waste, pseudo-disease, incidentalomas, etc. Does anybody know what an incidentaloma is? It's when they're looking for something and they find something incidentally. I interviewed this a senior radiologist at Emory University who had gone through what they call a virtual colonoscopy. So they take a CAT scan of his abdomen. Well, his colon was fine, but in the course of getting that test, they found that he had a little spot on his liver, he had a little something unusual in his lung, and something questionable on his kidney. And so he spent the next 6 months, including having a major chest surgery, to find that what they found, these spots, were incidentalomas. They weren't things that were ever going to go on to hurt him. The problems of overdiagnosis are vast, but there are solutions as well. This, I think, is maybe some of you are mathematical and graphs freak you out. This is probably the best symbol of overdiagnosis. And this is taken from a study, which I'm going to talk a little bit later. This is testing for thyroid cancer in Korea. And the reason I brought this up is because the Olympics are on right now, and why not talk about Korea? So the question is, can we do something to reduce deaths by thyroid cancer? So there's a certain percentage of people that will die from thyroid cancer. It's quite small, and it's actually a fairly rare cause of death, but it does happen. So if we can find unusual things in your thyroid and perform surgery or get you to take drugs, perhaps we can reduce your risk of death. Well, the risk of death in Korea of thyroid cancer, and this would be very similar in Canada and the United States and other countries in the world, the risk of death has remained steady from from the late 90s up till 2012. See that red dotted line indicates that the death rate of thyroid cancer has virtually gone unchanged in Korea over that 20-year span or so. But the finding of thyroid cancer, the amount of activity that has gone into looking for it, has meant that the actual incidence, what we call the age-standardized incidence of thyroid cancer in Korea, has skyrocketed. It's gone up through the roof. So this gap that you see, the gap between the, does that work? See this gap between the top of that line and that line, that is overdiagnosis. You have a huge amount of medical activity that's finding disease. It's never going to go on to give treatment to people that's going to save their lives. The death rate has remained unchanged, but the finding of thyroid cancer has gone through the roof. Those people who have their thyroid tested with an ultrasound are probably almost always perfectly healthy, even though if we were to test everyone in this room, we may find something unusual with your thyroid. Is it going to go on to hurt you? No. So there are excessive screening for all kinds of things that cause overdiagnosis. And some examples, there's many of them. I would argue that osteoporosis is a really good example. High cholesterol, Alzheimer's, overdiagnosis at ADHD, thyroid cancer, breast cancer, prostate cancer. Those conditions, I think, are often highly screened for and result in a lot of overdiagnosis, where people are treated for things which would never go on to hurt them. So osteoporosis is something that has kind of turned me into a bit of an activist, because it's such a controversial disease. Everything that I know about osteoporosis, I think, is controversial. That's what I said in my conclusion to the chapter in this book on osteoporosis, is that I have yet to find anything about osteoporosis that isn't controversial. The test itself is controversial in terms of, does it actually predict who's going to go on and have a hip fracture? Probably not. The diagnosis and the fear that's induced in women who are told they have osteoporosis and then are sometimes fed a lifetime of pharmaceuticals. Those drugs have very little benefit, and they all have some harm related to them. And when you are testing people for osteoporosis, you are taking often perfectly healthy people, and with one test, you're turning them into a patient that's not necessarily going to be healthier, but might now have this psychological weight on them. So do you need to be screened for cholesterol? And of course, we live in a world where probably 25 to 30% of the people watching this right now have been told at some point in their life they have high cholesterol and they need to take a statin drug to lower that. I would argue that cholesterol testing and the treatment of high cholesterol is probably one of the most overdiagnosed and unnecessary things that we do in medicine. And I know there might be a lot of cardiologists out there who would argue that I'm committing heresy, but I would tell them that in the world of cholesterol, there is a huge scientific debate between scientists around the benefits of treating or not treating high cholesterol. It's not just my opinion. This debate is happening in the pages of the British Medical Journal and other major medical journals. And arguably, statins do not have a proven health benefit in primary prevention, which is to say that if you haven't had a heart attack and you don't have established heart disease, your chances of benefiting from taking a statin are probably non-existent. And your chances of being harmed by the statin are, well, let's put it this way. When we've looked at studies about how long people actually stay on statins, we find some very surprising things. Something like 65 to 70% of people who are prescribed a statin will stop taking it within 2 years. It causes muscle weakening, it causes effects on your kidneys. There are lots of, shall we say, unknown side effects too related to statins. Some of the best research on the adverse effects, the side effects of statins has been done by a woman named Beatrice Golomb, who's a researcher in California. And if you were to Google her name, you would open your mind to the wide world of the adverse effects of cholesterol-lowering drugs. You have to have a screening test for Alzheimer's. So here's the thing, is that a lot of us, if we live long enough, we will develop some level of dementia and possibly develop Alzheimer's. It's a terrible disease. And oftentimes you will have your mother or your grandmother who at some point in their life can't even recognize the people that they love. The question, though, is can we do a test beforehand to discover whether there are some either genetic signs or some kind of biomarkers in blood that will prevent the progression of Alzheimer's. There hasn't been an effective test discovered yet, but they haven't started trying because there is a huge pool of potential patients who can be treated for pre-Alzheimer's with drugs and perhaps other treatments. I think there are some probably very important lifestyle things that we would need to do to maintain our brain health, including not taking statins. But screening for Alzheimer's, I think, is one of the probably the most disastrous things that we would attempt. Okay. So I'm going to talk a little bit about cholesterol. I don't know if you've ever seen this ad, but this was a full-page magazine and newspaper ad in Canada that ran a number of years ago. So the difference between my country, Canada, and the United States is that in Canada, we don't allow the direct-to-consumer advertising of pharmaceuticals. So the drug companies can't put ads in newspapers. Our television doesn't allow pharmaceutical ads, though, of course, we get a lot that come across the border in American television. We don't allow direct-to-consumer advertising of drugs, but that doesn't stop the advertising of disease. So in this case, the company, and now this is by a group that is an industry-funded, a collection of industry-funded patient groups and other organizations, making the connection. What they're trying to do here is basically what I would call good old-fashioned fear-mongering. They're giving you a choice. You can either have a cholesterol test or you can have a final exam. And let me tell you, it's not that simple. A cholesterol test will not prevent the final exam. I'll tell you that the companies are very, very clever. Because they're not allowed to advertise the drug, all they really need to do is advertise the disease. So that if you can get enough people concerned about their cholesterol, they'll go into their doctor's office where the doctor has free samples and has already been possibly visited by the sales people who are selling cholesterol-lowering drugs, and worried patients plus doctors who think statins will help people lead to prescriptions. Here's another example of an ad. Again, this is in a magazine in Canada. There are several of them. The toe tag ad is famous. This is the what we call the shark lurking ad. You know, living with high cholesterol, you could be surprised what's lurking underneath. I think that's an ironic statement because you would be very surprised if someone sat down and explained to you the risks and the very small benefits of taking cholesterol-lowering drugs. This guy is innocently sitting in his swimming pool, having a drink, and he's about to be attacked and eaten by the cholesterol shark. Okay. And of course in the US, so one of the things that I've noticed, and I remember coming to a conference here about 10 years ago in Washington, D.C., and there were ads in the subway telling people to know their numbers. And I was like, what do you mean know your numbers? What numbers do I have to know? Well, it was a campaign to get people to go out there and get their blood pressure and their cholesterol and their blood sugars checked, because you should know your numbers. I thought, why would you want to know your numbers? What is knowing your numbers going to do? I can tell you, knowing your numbers is going to it'll help you become a person obsessed with their numbers and sort of stop living so that you can do stuff to affect your numbers. What you may not hear in the sort of cholesterol world is that there is an intense debate in the medical community about the value of cholesterol-lowering drug. And there are people studying what I would call disease mongering around high cholesterol. They're studying the impact of telling huge numbers of people that they should be concerned about their cholesterol because of the sharks lurking or the toe tag that's awaiting, and they should get out there and check and know their numbers. This is all, in my opinion, leads to a lot of overdiagnosis. So I thought instead of talking about statins obliquely, I should give you just one example of a study. And I should argue also that you should never look at individual studies in isolation. You should always look at what we call the meta-analysis. You take all the studies that have studied the same question on a similar patient population, and you see what those overall studies look like. This is essentially what the Cochrane collaboration does. So the Cochrane collaboration does essentially meta-analyses, these large overview studies looking at how do all the studies when you put the results together, what kind of results you get. So I'm going to talk about just one study that you would find there are probably a dozen or so major cholesterol-lowering drug studies, statin studies, with various products. One of the early ones, and I think I chose this one because this one showed the best result of a cholesterol-lowering drug. So this is it was the Scandinavian simvastatin study, also called the 4S study. So they would take, I think, 60 to 75-year-old Scandinavians, overweight, mostly men, and in that group they would put, and these people, by the way, have had a previous heart attack or established heart disease. So this is the highest risk group of people that you could find. And I don't know why they had to go to Scandinavia for this, but so you've got a high-risk group of people. Some of those people in the course of the study, and the study is over 5 years long, some of those people would get a cholesterol-lowering drug. In this case, it's simvastatin, which goes by the trade name Zocor, I think. Some of them would be getting the placebo, half of them. So you would follow these more than 4,000, mostly men, for 5 years to see how many of these high-risk men had a heart attack if they took the statin versus how many had a heart attack if they took the placebo, okay? So, but just let me ask you, out of 100 people, like people in this group, they have high cholesterol, they've got established heart disease, how many are going to have a heart attack in the next 5.4 years, okay? I'll give you a couple of examples, a couple of options. Is it 8 people? About 8.5%? Is it 29 people? Or is it 55 people? So out of these 100 high risk, the highest risk people they could find, put them in a trial and then follow them for 5 years. How many of them are going to have a heart attack? Oh, sorry. How many of them will? How many of them will have a heart attack in the next 5 years? Right. It's you guys are savvy. It's about 8.5 people. So the question is, can we reduce that? If your risk is 8.5% of having a heart attack in the next 5 years, can we reduce that? We can't reduce it to 0, but maybe we can lower that number a little bit. And there's a couple of ways that we can do this. We could do it with a cholesterol-lowering drug like simvastatin. But would you take this drug every year if it offered these benefits, okay? One of them, it's going to reduce your risk of a heart attack by 42%. Okay? What if you're told this drug will reduce your chance of a heart attack by 3.5%? More modest, but it is what it is. Or 29 people have to take this drug for 5 years to prevent one heart attack, but there's no way to know who it will be. I mean, there is never any way to know who is going to be the lucky one person who wins the lottery out of the 29. So if this information is presented to you in this 3 different ways, how do you think the pharmaceutical industry presents this information to your doctor? Or to you, sometimes through patient information? It's going to be the first way. They're going to tell you, take this drug, it's going to reduce your risk of a heart attack by 42%. Because you're going to say 42%, that's a big number. I'm kind of interested in having my risk reduced by 42%. But let me show you what the trick is here. It's the same data. It's the same thing, okay? So here you've got, we've got 2 graphs here. They're coronary death and all deaths, okay? So let's just look at the coronary deaths. So remember I said 8.5% of the people, those poor people that had the placebo, 8.5% of them died from a heart attack in that 5-year period. But if you took the drug, only 5% died. So I'll just see, let me just see if I can do this. Yeah, see there, right there? So if you go from 8.5 down to 5, that's a 42% reduction, right? So 5 is 42% less than 8, right? But really, the more honest way to show this data is that you go from, again, 8.5 down to 5, you subtract those 2 numbers, you have a 3.5% difference, okay? So you're at what we call your absolute benefit of that statin drug is about 3.5%. I mean, I don't have established heart disease or have had a heart attack and been offered this, but that's the absolute benefit in 5 years, about 3.5% difference. Again, this is the best statin study I could trial. Most of the statin trials, when you look at the meta-analysis, that difference might be 2 to 3%. So you have to treat 29 to 35 or so people to prevent one heart attack. So, okay, you've got a room of 35 people. I'm going to give you all statins for the next 5 years, and you have to deal with the cost and the inconvenience and the side effects, possibly side effects of that drug, and one of you will be prevented from dying from a heart attack. Is that good or bad? Well, it is what it is. I'm not going to make any, but you could probably draw your own conclusions what I think about that. Overall deaths, a little bit less, about 3.3%. So there's a couple of things that I think that, the takeaway message about statins and why I think this is a classic example of overdiagnosis is that high cholesterol is not a disease in and of itself. This obsession with what your numbers are is almost irrelevant to the length and the quality of your life. I've never had my cholesterol tested. I don't know what it is, and I don't care. I've read the meta-analyses of the cholesterol-lowering drugs. It wouldn't make any difference to my life. It might make me worry, but it's not going to make any difference to what I'm going to do and the way I'm going to live. Yeah. So for those people at the highest risk, so these are, if you're an overweight Scandinavian who are between 65 and 75 years old, for example, and you've had established heart disease or you've had a previous heart attack, you might have some benefit from taking a statin. But if you're like everyone else, if you're a healthy middle-aged person and you're told you should take this cholesterol-lowering drug because it's going to reduce your risk of a heart attack, the question you might have is, well, how much is it going to reduce my risk? Because for people people who don't have established heart disease, who haven't had a heart attack, the risk is, or the benefit is, some would argue, zero. There's either no or very little benefit in giving healthy people, otherwise healthy people, statins. And the real scandal, I think, is that probably in the community, 75 to 80% of the people who are taking statins will not benefit from taking those statins. At the same time, there might be underdiagnosis in the people that do have established heart disease, have had a heart attack, and they might have some 2 to 3.5% benefit, and they may not be taking statins, right? So, and the side effects and the adverse effects of statins have long been, I think, underplayed. And I often will get calls from people when I'm writing an article about cholesterol-lowering drugs. Someone calls me and says, Mr. Cassels, I'm taking this drug, Crestor, and it's giving me this, I can't get out of bed in the morning, my muscles are weak, I can't go upstairs. And I said, well, have you considered it might be due to the drug? He said, yeah, but when I went to my doctor, the doctor said it couldn't be the drug. He'd never heard of that. I said, well, you can tell your doctor that is the most known side effect related to statins is muscle weakness, right? Do you have any problems with your cognitive abilities? What do you mean? Well, do you forget things? Are you kind of maybe not thinking as well? Because that's also a known side effect related to statins. Any drug that you take has a possibility of helping. It also has a possibility of harming. And that's really why we have to be very careful about overdiagnosis and taking healthy people and turning them into patients. So there's many ways to describe this. I mean, people have described overdiagnosis as misdiagnosis. Some have said, the problem is the expanding definitions of disease. People have argued that there's simply too much medicine. There's lots of potential for false positives. And at the same time, there are people who are trying to counter this. The right care movement, the choosing wisely movement, the less is more movement. And it's possible this is the first time you've heard about these concepts, but this does give me a ray of hope, because for the last 6 years, there has been an annual conference called the Preventing Overdiagnosis Conference. I've attended 5 of the 6 of these conferences. Just hang on a sec. So these are some of the organizations that I think are starting to get on board with this concept of overdiagnosis. The British Medical Journal is one of the I think, leading academic journals that's taking this on. You've got various other groups, Too Much Medicine. You've got... let me see one more. Yeah, you've got the Dartmouth Institute, you've got the JAMA Network, Right Care, the Lone Institute, really one of the leading groups that is working to wind back the excess of too much medicine. Consumer Reports are involved in the Preventing Overdiagnosis Conference. You've got the Foundation for Informed Medical Decision Making, who I think produce some of the best high-quality information. Society for Patient-Centered Orthopedics. These are all the people that you would see attending and being involved in both research and kind of activism around preventing overdiagnosis. And there, I took that this morning as a screenshot from the Preventing Overdiagnosis Conference. This year it's going to be in Copenhagen in August. Last year it was in Quebec City in Canada, and the year before it was in Barcelona. These are fabulous conferences where you've got both physicians and researchers and patient advocates who are really trying to say, what can we do to really stop this medical juggernaut from enveloping and consuming our lives? I would invite you to check out that. What I like, though, is what they use as their symbol. Remember what I showed you, that graph about the thyroid, that idea that we're very good at finding more disease, but are we actually that good in preventing people from dying from certain conditions? So Choosing Wisely is one of the groups that's involved. I don't know if you've heard of Choosing Wisely. I'll talk a little bit about what they've done here in the U.S., but they're in various countries around the world, in Canada, the U.S., and Brazil, and Australia, and many countries in Europe. It's a campaign to help clinicians and patients. Really, it's about engaging in conversations, really. So what I like about it is that they ask professionals, give us examples of things in your own profession where there's overdiagnosis happening. So they ask the orthopedic surgeons and the cardiologists and the neurologists and all of these specialties. They ask them to give examples for which they think themselves that there is overdiagnosis happening. And so the Choosing Wisely people were able to take these and kind of meld them down into discussion points and sort of educational stuff for physicians and for consumers. Choosing Wisely is active in Australia, And in Israel, I like that little graphic of the cat. This patient needs a CAT scan, right? Meow. Again, each country, has researchers and policymakers and consumers involved in trying to promote this idea of doing things to prevent overdiagnosis. In Japan, choosing wisely is in Japan. Let me just show you this a little bit more. Remember I told you about the incidence of thyroid cancer in Korea. I just want to read that. In 1997, in a small town of Yongkwang in the southwest, a doctor opened a private internal medicine clinic. For some reason, he decided to provide patients ultrasonography screening for thyroid cancer. It did not take long for him to be admired for saving many lives by detecting early thyroid cancers. The news rapidly spread to the nearby towns and cities, and clinics in other areas subsequently joined in the frenzy of detecting thyroid cancers. Through screening. It was not a bad thing for doctors to detect early cancer, since that supports this idea that you can prevent death by doing this kind of screening. Again, this is really the sort of poster for overdiagnosis. You can detect a lot of disease if you look, but the question is, are the people essentially living longer? Okay, and in this case with thyroid cancer, the people that die from thyroid cancer hasn't changed over that 20-year period, but the finding of disease has grown rapidly. I met this guy at the National Institutes of Health a few years ago when the Preventing Overdiagnosis conference was there. We were sitting on the bus going into the NIH, and we started chatting, and he said, "What do you do?" And I said, "Well, I've written books." And so he knew me, but I'd never heard of him before. And he was the keynote speaker at the conference, speaking on this various issue, this idea of preventing overdiagnosis of thyroid cancer in Korea. And so these physicians, they discovered, oh my God, we are creating huge amounts of harm in the population by giving people ultrasounds of their thyroids. We should stop doing that. And they created a national campaign, and they've turned the curve on that. They've essentially told physicians and patients, stop getting your thyroid screened, because it's going to lead to a lot of overdiagnosis. People will end up having surgery and taking drugs, and it's not going to extend your life at all. That's just for humor. That's a radiologist selfie. Yeah. So in Canada, it's been identified. This is CIHI, it's the Canadian Institutes of Health Information, and they've started looking at what's the rates of unnecessary and overdiagnosis in Canada. They estimate that, and we've got a public health system. It's fairly different than the U.S. system, where because the public is paying for things, they're much more restrictive in what they pay for. Sometimes appropriately, sometimes you wish they weren't so restrictive. You wish the free market would take over. But I can tell you, even in a restrictive system, they estimate that 30% of patients, well, in this case, up to 30% of patients indicated in these choosing wisely recommendations had tests, treatments, and procedures that are potentially unnecessary. And they estimate that about a third, in a conservative figure, about a third of healthcare spending is wasted. And this, when I say wasted, it's spent on things that are unnecessary. It leads to overdiagnosis. It leads to healthy people being turned into patients unnecessarily. So here are just some examples that choosing wisely suggests that people should question, right? For example, the radiologist says, well, don't do imaging for lower back pain unless red flags are present. A lot of times you go in with a back pain and someone will say, oh, you need a CT scan. Well, the benefits of a CT scan in diagnosing your lower back pain, I think, are probably vanishingly small. But while they're doing a CT scan of your lower back, they're exposing you to, radiation that might be the equivalent of 300 to 500 chest X-rays. And in fact, we have seen that the overuse of CT scanning in the United States has led to an increased rates of certain types of cancers because we're causing cancer by over-testing people. This is the second one. Don't use antibiotics for upper respiratory tract infections that are likely to be viruses, right? But this happens all the time. You've got the kid who wakes up in the middle of the night screaming, and the parents are clearly concerned. But what do? They'll take the kid to the clinic, and they'll demand that the kid gets an antibiotic because he's got an ear infection, for example. Well, there's a good chance that the antibiotic's not going to help. It might give the parent some sense of relief that they're doing what they think they should. But the overuse of antibiotics, as you know, has been identified as a major health problem. We're using so many antibiotics. We're developing more and more intense infections that can't be treated by antibiotics, right? Don't order screening chest x-rays and EKGs for asymptomatic or low-risk outpatients, which I thought I was when I went and got that EKG test. Any test has the potential to deliver a false positive, which means they tell you that you have something that is going to go on to hurt you when it may not be true. They also do false negatives as well, which is there may actually be something wrong with you, and the test says you're perfectly healthy. So there is a problem in terms of the accuracy and the sensitivity of a lot of screening tests. Don't screen women with pap smears of under 21 years of age. There was a study where they were screening nuns. Nuns, wow. And the question being is that, well, if you don't have sex, you're unlikely to develop anything that a pap smear is going to help detect. Don't do annual screening blood tests. Okay, so this is something that I have spoken about and I've argued with others about. Is this the idea of having the annual physical? The annual physical being, well, I feel a duty to myself and my family to go to my doctor. I don't have any complaints, but I'm going to go to my doctor, schedule an appointment so he or she can run a bunch of tests on me to see if I have any signs of disease. In theory, that sounds like smart preventive health. In practice, though, what happens when healthy people go, if you're already healthy, it's unlikely the doctor's going to make you healthier. So what's likely to happen if you're already healthy is that you will get possibly tests that will lead to treatments that may make you worse off. You can take your so the whole annual checkup is being drawn into question. Is that if you're perfectly healthy, going to the doctor for just an annual physical is not a very wise thing to do. But if you have any problems whatsoever, any symptoms whatsoever, you should see your doctor. That is a good reason to go and visit your doctor. I'm not saying don't avoid doctors. But I'm saying avoid doctors for unnecessary visits and perhaps to make you feel that you're doing your best. This idea of measuring vitamin D in low-risk adults, this is controversial. There's some research that says vitamin D, we're all vitamin D deficient, and it's causing all kinds of health problems and other diseases. Others research which has said we are actually, by using supplements, vitamin D supplements, we're actually increasing certain types of risk. I would say that the jury is probably not in yet about vitamin D. But what they're saying here is don't be testing people routinely for vitamin D. You're just going to make them worry, and you're probably going to force them to go on to take supplements. Well, maybe people will spend more time in the sun, which might be a good thing. But if you're otherwise at low risk, there's no benefit of this, according to the Choosing Wisely people. Routine screening mammography. This says for average risk women aged 40 to 49. I mean, it used to be, and when I spoke about this the other night, they used to recommend women 35 and over get an annual mammogram. This was in the early 90s. And I can tell you they don't do that anymore. In fact, most countries in the world, they would say that women should start semi-annually screening at about age 50. Others are arguing that the advantages of screening mammography are vanishingly small. You have to test something like 2,000 women, give 2,000 women mammograms every year for 10 years to save one life. So which means that the yield for annual mammography screening is very low. And I know there's another speaker here, Ben, who argues that mammography is actually increasing your risk of developing breast cancer. So even for the choosing wisely people to say, don't offer screening for women under 50, that's a start. I mean, it's probably, I would say, not the strongest bit of advice, but that's a start. Again, the number 8 there about annual physicals on people that have no symptoms and no significant risk factors. So that number 9, don't order DEXA. This is the dual energy X-ray absorptiometry screening for osteoporosis on low-risk patients. The osteoporosis industry is huge. It's monolithic, and as I said before, it has so much controversy around it. The idea that you can somehow improve someone's bone density so that they're going to avoid the worst aspects of osteoporosis, which is falling and breaking a hip. That idea is simply not true. There are ways to stay. So osteoporosis is a lot of it is about I would say fear mongering, mostly women, that as you get older, you're going to lose bone density, and therefore you should do something about it. You should get it measured. You should check your numbers. You should check your numbers. You should alter your diet or start taking pharmaceuticals to try to reduce your risk. Things like Tai Chi and yoga, very good for people, especially as you're getting older, because the most important thing about hip fractures is falling. It's not having low bone density, it's falling, right? And so when you look at studies on, who are the people that are falling and breaking their hips, what's that associated with? Well, it's associated with taking certain types of sedative drugs, benzodiazepines, so people get dizzy, maybe taking too many antihypertensive drugs, too many drugs to lower your blood pressure. So grandma stands up in the morning, and because she's on 3 antihypertensive drugs, she gets dizzy and she falls down, she breaks her hip. Whether she had low bone density or not is irrelevant in that equation. If she's going to fall at that age, she's going to probably break something. And for a lot of elderly people, falling and breaking a hip can be the beginning of the end. I mean, this can lead to hospitalization, and of course, once you enter the doors of a hospital, your likelihood of developing other infections and sepsis or being given other things that aren't likely helpful increases. Anyways, what's the last one there? Oh yeah, thyroid function tests, of course. If the doctor is coming at you with an ultrasonograph and wants to test your thyroid, you might just say, I don't believe there's any benefit in doing that, and please don't try to turn me into a person that's now worried about his or her thyroid. By the way, thyroid conditions are really common, really. There are, if you look in the top, say 20 most prescribed drugs in the United States, there's going to be drugs that treat thyroid, levothyroxine. Probably 2 out of 5 women that I know, my age and older, have been diagnosed with some level of thyroid dysfunction, and they're taking drugs for that. I don't know whether that's really a wise thing to do, but it really demands us to ask, why do we see so much thyroid disorder in mostly women? I'm not sure. But certainly testing thyroids with ultrasound is not a good idea. So this is the Choosing Wisely Canada suggestions on, these are just questions you should ask your doctor. And I would argue that the best way to prevent overdiagnosis is to have an informed and involved and a questioning patient. I have found it personally very difficult to challenge my doctor because he's a doctor. Believe it or not, the other day he tried to get me to take statins. It was, we all need a little bit more courage. And I think if you've got a good doctor's going to accept questions, and good questions, It's not an emergency to do something about some high level of your cholesterol, or if your blood pressure is slightly elevated. These not are emergency situations. You have time to ask questions and then to question the answers that you get, okay? And, I like the last one the most. And I have at the end of my book on screening, I tell this anecdote about my son. So we're in the dentist, and he's being told that, we took him to the orthodontist, because that's what good parents do. And the orthodontist said, again, don't ask a barber if you need a haircut. So the question is, does my kid need braces? Braces are expensive. It's a fairly invasive thing. Braces are very common, though. So the dentist takes X-rays and photographs, and it was a very slick kind of operation. It had these big screens with, focusing in on your kid's mouth, and the orthodontist. This is a very educated, wise person saying, we can see some problems down the road, because his jaw is growing in this way and his teeth are he had his adult teeth, but he still had a 12-year-old jaw, right? And I got common sense. I went, well, his jaw's going to get bigger. And that's what I challenged the orthodontist with. I'm not going to go and, spend $6,000 and get braces right away, because common sense tells me that my son's jaw is going to get bigger. If he has crooked teeth as he's older and adult, he'll have a job. He can pay for the orthodontics himself. Right? By the way, the son was the second one. The daughter, she did get braces. Because I was just like, well, whatever, doctor. I was like Bambi in the headlights. And you've got this professional coming at you with this advice. You just go, well, okay, I guess so. Anyways, I was prepared to challenge, because I started doing some reading. I'm like, they're asking people to see the orthodontist with a 12-year-old kid who has not finished growing. I mean, he was like this tall at 12. He's now this tall at 18, right? And his face is perfect, and his teeth are perfect. Yeah, I was right. His jaw grew, and his teeth fit perfectly, and he's got a nice smile. He's very lucky. He looks like his mother, But, so what I said in the book, when we were at the orthodontist gives us this big spiel, and my son's in the chair, and the orthodontist says, do you have any questions? And I said, well, I already told you my questions, like, isn't the kid's jaw going to get bigger? And my son said, what happens if I do nothing? Right? The orthodontist was basically had the forms there. Sign the forms, we can get you going, we can get you on a payment plan, we can get this thing happening. Right? Like, it was kind of like a move it along. My son was, what happens if I do nothing? And I was so proud of him at that moment, because I said, he's been actually listening to me, over the years, when I said, doing nothing is sometimes the right thing to do. And he was asking the doctor, and that's a very good question to ask a doctor. Oh yeah, so I've got high blood pressure. What happens if I do nothing? He said, well, you'll have a slightly increased risk of a heart attack. Okay, well, how much increased risk? And the doctor should be able to answer that question, because they have cardiovascular risk reduction tables. They can tell you, if you're, like me, 54 years old, my cholesterol level, if I measured it, was this, my blood pressure is this, my hemoglobin A1C is this. They say, well, your risk of having a heart attack over the next 10 years, given the numbers that we put in this calculator, your risk, Mr. Cassels, is going to be 6%. Okay, so what happens if I take a drug to lower my blood pressure, because you might think it's high? Well, we could reduce that risk in the calculator. Yeah, it'll drop it down to 5.8%. Okay. So what you're telling me is that I can take a drug every day for the rest of my life to reduce my risk of having a heart attack by 0.2%. That's really not worth it to me. Anyway, so when someone is coming at you, so doing nothing in this case, doing nothing is the right thing for me. Everyone might have a different sort of choice about that. And people worry also about their family history, right? Because a lot of times they'll say to you, oh, Mr. Cass, your mother had a heart attack, your father had cancer. You're at high risk of those things. Say, well, don't give me that. the leading causes of death in this country are cancer and heart disease. Of course, if I live long enough, one of those two things are going to get me, unless the third thing could be a shaving accident and I bleed to death. Anyways, I go on. I mean, the choosing wisely, and I think in the U.S. as well, they've got posters and patient-oriented stuff that is just trying to make a little bit of light fun about too much medicine, right? And you know what? I chose this one. There's a bunch of them. I chose this one because I really like mustard, and I like a little bit of mustard on a hot dog. I can tell you that is not very appetizing, and it's just like that with medicine. I think a little bit will make things better. Too much. And well, so what are my proposed solutions? And I think I kind of melded this down to three. That, you know, there is far too much waste in overdiagnosis. Medical screening, and you know, in this book I go into 10 different examples. I use 10 different types of screening, from osteoporosis screening to screening for eyeball pressure, which I used. You know, when you're writing a book, you always need a patient. You need a person to sort of be the narrator. Well, I'm the narrator in the screening for eyeball pressure chapter, because I had my wife dragged me to the optometrist, and the optometrist says, I'm going to do this test where I blow a little bit of a puff of air into your eye, and it's going to show me what your eyeball pressure is. I said, well, I'm glad you're doing that, because I'm writing a book about screening right now, and you're giving me a screening test. And he said, oh, okay. And I said, so what are you going to find with this screening test? And he said, well, I can determine whether you've got high eyeball pressure. Well, that's nice. Do I care? Well, you know, it could lead to glaucoma or other forms of eye disease in the future. I said, well, what's the likelihood of my high eyeball pressure ever going on to hurt me? Well, I don't know. You know, it could happen. So how about some numbers here? Anyway, so finally I got to the point, you know, Mr. Cassels, you're being a difficult patient. Stop asking questions. So what I write about in that chapter is how difficult it is to ask the questions. You know, when someone's coming at you with a screening test, to be able to sit back and say, hang on a second. Before you do that test, I want to know, what is the potential benefits? What's the downstream risks? What are the potential for you taking this reading and turning me into a patient? That, you know, one day I'm just a normal person who went to the optometrist. The next day I'm a guy that's worried about his eyeball pressure. And of course my glasses make my eyeballs look bigger. So, you know, I'm already worried about my eyeball pressure. I would argue also that over-treatment for all of us is a bad thing, but it's really harmful in the elderly. Okay, our parents and our grandparents, the amount of pharmaceuticals and tests and treatments that older people get turn their lives into a lot of medical busyness that never really goes on to help them, and it causes a huge amount of stress in families who have to look after their elderly parents. You know, everyone experiences this at some point in their lives, where your life becomes consumed with managing mom's pills and mom's doctor visits. And I would argue that all of this medical activity would be great if it actually improved the quality of mom's remaining days. But mom's remaining days becomes checking her glucose and taking her cholesterol-lowering drugs and worrying about whether she's going to fall because she gets dizzy sometimes. And so the over-treatment in the elderly, I think, is one of the scandals in our countries, and we have to, you know, do something about that. Again, the same sort of thing, polypharmacy. So, you know, luckily, the idea of polypharmacy, which means taking multiple drugs. So drugs are typically tested in isolation. You'll take, you know, a patient with a certain condition, you'll test a drug in those patients against a placebo, and you'll follow them and see what kind of differences there are. I'm being a little simplistic here, but that's essentially what happens. But when the patient gets out in the community, the patient isn't on just one drug. The patient's already on a cholesterol-lowering drug, a drug for their osteoporosis, one for their eyeball pressure, one for their asthma, and so on. And so people end up getting far too much medicine, and those drugs interact with each other. And I remember when my mother had a heart attack, and she came out of the hospital, and she was like on she was still in the hospital, and she was on about 8 different drugs. She'd only been on a couple before she went in the hospital, but the hospital just kind of threw this armamention of pharmaceuticals her way. And I challenged the nurse. I mean, I'm not a bad person, but I challenged the nurse. I said, "Really, does Mom need, like, what's this one for?" "Oh, that's," so they, and finally I got fed up, and I said, "Can I speak to the hospital pharmacist?" And they made an appointment for me, and I went and spoke to and I said, "My mother's on like 12 different drugs now, and she was only on about 2 or 3 of them when she came into the hospital, and she just had a major heart attack. Granted that, I would expect her to be on perhaps other drugs, but 12 drugs, I mean, do you know how those drugs interact, what they're doing to her?" And the pharmacist said, "Well, that's just what we do." It was like, what you're asking is a question. You go into a hospital, you're going to be put on a lot of drugs. That's kind of the way it works. And I'm like, I don't like the way it works. I have my own experience in getting surgery, and as I was leaving the hospital, in addition to getting a script for 100 OxyContin, which I didn't fill that one, but there were 7 different drugs that I was being prescribed, and I realized that some of the drugs were being prescribed to treat the expected side effects of other drugs that I'm taking. And I'm like, really? So, for example, I'm given a drug for GERD or heartburn. It's a pantoprazole. It's a proton pump inhibitor. Effective drug if you've got GERD or heartburn. These drugs work, and some people get on them and stay on them for the rest of their lives. And I say, "I've never had GERD in my life. Why are you giving me this drug?" "Well, that's to counter the side effects of the NSAID that we're going to give you." "Yeah, but I don't have any side effects of that NSAID." "So, oh, but you might." "Oh, okay." So this idea that you would not even give treatments for things that people actually have, you're giving treatments for people for things that they might have. Anyways, I think there needs to be an awful lot of more pushback when it comes to overdrugging our seniors and ourselves. And I think this is probably the most important thing too, is that people have to be involved in medical decision making. So health literacy is astonishingly low in this country. People who don't really understand what the doctor's saying, therefore will assume that the advice is good and correct, and sometimes it is, but they're not perhaps literate enough to challenge what they're being told. And I think that doctors are good people. They want to help, and I think that they will answer people's questions reasonably if you ask respectfully. Some physicians will hate being challenged, and then it might be time to find a new physician. Okay, and I think that asking reasonable questions about when you're being offered a test or a treatment is really important. So again, those are. I think I've already had this. Do I really need this test treatment procedure? What are the downsides? Are there simpler, safer options? And what happens if I do nothing? So I'm almost at the end here. You always have to have the Viagra joke. So, "Doc, can you write me a prescription for some of that Viagra?" And the wife has got the... This is funny, but it's also in a way touching in that any drug that you take that affects other people, clearly those other people should have a say in whether that's necessary or useful or even desirable. Okay? So what do I spend most of my time doing? Yeah, hitting my head against the wall. But I hope you guys have some good questions. And so you have to be careful of reading health books because you could die of a misprint. I always like to end with that. And that's my contact information. My website's not working because my guy hasn't fixed it yet, but I'd be happy to answer any questions, Steve, or anyone that. So, do we have a microphone that you can pass around? Oh, right here.
Can you say a few words about this, treatment for blood pressure and blood sugar level? Because the target seems to be moving yearly, depending upon consensus of physicians.
Yeah, you're absolutely right. There is a huge controversy within the world of cardiology and hypertension about what the optimal blood pressure target should be. And frankly, that has changed over the years. When I wrote Selling Sickness, I interviewed a cardiologist in North Carolina who told me, it used to be we would have patients coming in, their blood pressure would be 160/90. We'd say, yeah, it's slightly high. Don't worry about it. He said, now, if we were to do that, we would be accused of malpractice. Right? Because, if you're not treating someone who's got a blood pressure of 160/90 over 100, then, you're doing something wrong. As you know, with blood pressure, there are many non-drug things that you can do to reduce your blood pressure if you're worried about, affecting your diet, your exercise. There are other things that, as well, there are, I would say, a fair bit of overdiagnosis when it comes to high blood pressure, because the question is the machine reading it properly? Are you actually more nervous in the doctor's office and therefore have higher blood pressure than you would normally be? Don't laugh. There's a phenomena that they've studied. It's called white coat hypertension. And white coat means when you've got a doctor with a white coat and he's taking your blood pressure, you're in the presence of a professional who's looking after something very important for you, your health. Of course, your blood pressure is going to be slightly raised. And you drank 3 cups of coffee before you got to the doctor's office, so your bladder's kind of full. That'll raise your blood pressure. Maybe you ran to the doctor's office or ran up a flight of stairs. That'll affect your blood pressure. So this question of targets, I'd say that the best information on hypertension, if you're interested, is produced by the Cochrane Collaboration. So these are the people that I write about in this book. And so they look at all of the studies on hypertension, and most recently the Cochrane Hypertension Group has said that there is no benefit to lowering blood pressure from 140 down to 120, right? So even though major professional groups around the world are saying, normal blood pressure should be 120/80, something like that. Well, if your pressure's 140, then you need to be doing stuff. And they're not necessarily saying you need to be taking drugs, though that's kind of the hidden message, because a lot of times the lifestyle things you do aren't going to bring them down. But what happens is that many people are going to be put on 1 and maybe 2 and sometimes 3 antihypertensive drugs. So now you've got 3 drugs that you have to take every day to bring your pressure from 140 down to 120, when in fact there is no benefit in doing so. There's no statistical benefit that you're going to live longer and healthier at having a blood pressure of 140 versus having one at 120. The difference in the length and quality of your life is not going to change at all. So if you've got pressure 140 and everyone's telling you, you got to bring that down to 120, they are trying to turn you into a patient. They're trying to get you to worry about your blood pressure and possibly do things to change it. Now, those things that you should do anyways, like eat a good diet and exercise and don't smoke, and those sorts of things are important. Blood pressure is only one small component of your overall health, though. And I think that certainly in the elderly, when you're older, your blood pressure naturally rises. Your arteries become thinner and more brittle, and so it's normal to have a higher blood pressure when you're older. When I'm talking older, I mean 75, 80, 85. But what happens is that often physicians will say, well, you're 80 years old and your blood pressure is 150. We got to bring that down. When in fact, that might be perfectly normal or near normal for someone that age. And they're expecting to take this down to 120, the same blood pressure you had when you were 30 years old. So there is, I believe, a fair degree of disease mongering around blood pressure and a fair bit of overdiagnosis. And I would say, unless your blood pressure is to the moon, most people would benefit from just having altering their diet and changing their lifestyle to, if you're worried about your blood pressure. My mother's on a couple of blood pressure drugs, and I asked her, so what's your blood pressure? And she said, well, it's normal. So, well, why are you on these blood pressure drugs? And so when I went with her to the doctor to talk about this, the doctor said, but if she wasn't taking these drugs, her pressures would be a lot higher. And, as a son looking after his mother, I'm thinking, yeah, but what's the likelihood of her benefiting from taking these drugs to bring her pressures to the level that they are? And I know that there's very little benefit. At the same time, I can't challenge a doctor. I'm just an ordinary person, He's a doctor. She's a doctor, right? So, and other questions? I think right here and then here. I'd be happy to talk to you about a little bit more about that afterwards if you like, okay?
Hi. Thank you so much for speaking. It's so wonderful to hear all this information. The question I have is, you had said that you should see the doctor when you have symptoms. And then oftentimes when I've gone to the doctor, I get yelled at because I was told, and this is a pretty, holistic, very involved doctor who knows how to treat on, at different levels, not just, Western and medical. But I'm told you're coming in only to see me when there's a problem. So I said, well, that's why I do come in. Well, you don't come in for your annual checkups, and you don't come in often to see me and get your blood drawn and all that. And she's a pretty, like I said, very intelligent woman. But what symptoms besides the obvious, like, black stools or pains or lumps, like what other symptoms? I mean, I'm not listening to her. Yeah. I do go in when I have a problem that I see, but what real symptoms do you think that we should be seeing a doctor for?
Well, broadly speaking, anything that you're worried about.
Well, if you're worried about everything, because they're telling you that you should come in and see me. You shouldn't wait till the last minute when, you have.
Yeah, I don't know what's going on there, and I would be appalled that a doctor would yell at me for not coming in when I'm perfectly healthy and have no reason to be there. If you have a good reason to go to the doctor in your own mind, I would say that's good enough. Don't avoid the doctor because you think you're going to be overdiagnosed. If you have something that concerns you and you think needs to be checked out, don't hesitate. And sometimes people do. My whole talk is about overdiagnosis, but there is problems of underdiagnosis as well. I mean, and I would say that they're sometimes as grave. You get some people who are just. A friend of mine who died very young with diabetes. He was a writer, a poet. He was a really big guy, though. He drove a Harley motorcycle, and he was a great writer. And clearly, he had signs of diabetes. We could all tell, right? He was thirsty all the time. He drank lots of Coke and other things, but and he clearly had signs of diabetes. He needed to go to the doctor, and he didn't. He didn't until one day he just died. He had clearly something that could have been prevented, could have been treated, and it's a tragedy that we didn't kind of force him to go and see the doctor. So I don't know if this is an easy answer to your question, but if you're worried about anything related to your health or your son or your children or your parents, that you shouldn't hesitate. So do you want me to answer a question about colonoscopies? So I have a chapter in the book about colonoscopies. There's various ways to inspect your colon to see if there's signs of cancer. There's, we'll say, three major ways. The first one is what they call a fecal occult blood test, also known as the poop test, where they can inspect your stool to see if there are signs of blood in it, and if there are. you can get then you may be referred for a colonoscopy. Colonoscopy uses a thin, flexible tube that goes up into your colon, and it's got a little camera and a little optic sight, and it looks inside your colon. That's the second way that you can get sort of tested or screened for colon cancer. And the third way is a virtual colonoscopy, where they do a CT scan of your abdomen. And that is probably the least recommended, and some would argue the least helpful. It exposes you to a lot of radiation, results in a lot of incidentalomas, which means they're finding things that by the way, perhaps in other organs. So what I say in the book is about colonoscopies is that, in my opinion, the jury is still out on the benefits of screening with colonoscopy. So I'm not talking about, if you have any symptoms, again, let's be clear. If you have any symptoms related to your bowel movements or your colon, and you see blood, you should definitely go to your physician and ask for, some kind of diagnostic test to see what's going on there. The thing is, if you, this fecal occult blood test, there are some things that cause false positives. If you have a nice rare steak the night before, and you do the FIT test, guess what? They're going to discover blood in your stool. And so you shouldn't freak out because it's what you ate. It's not perhaps coming from you. It's coming from that steak that you ate the night before. Colonoscopy, I still think it's controversial. There are some who would argue that the benefits of colonoscopy is that once they're in there, is they can, if they discover polyps, they can remove them. Okay, polyps meaning a little, you know how sometimes you get these little loose bits of flesh that hang off various parts of your body? Well, you have those on the outside of your body. You also have them inside your intestines and in your colon as well. And so they can remove them. The question is, if they remove them, is that going to reduce your risk of developing colon cancer in the future? Well, some would argue yes, because those polyps are precancerous. They may be a sign that you're going to develop colon cancer somewhere in the future. That's what some people argue. Other people argue that, it's really invasive to go in there and clip off these little bits of skin that are hanging down, because when you do that, you actually may be making things worse. So there's that school of thought. They in Canada anyways, they say once you turn 50 years old, you should submit to the, every 2 or 3 years get this fecal occult blood test, and if it's positive, then you get a colonoscopy. Some people say, oh no, I need a colonoscopy right away. I'm going to go to the States and get it because, the cheap Canadian healthcare system won't pay for it. It's not quite true. If you have any symptoms and they think that there's a benefit of having a colonoscopy, they'll pay for it, and you'll get one for free. Yeah, so I think the jury is out on colonoscopy. In fact, when I was asked by journalists after this book came out, I did some media interviews, and journalists say, well, Mr. Cassels, of all these screening tests you're talking about, breast cancer screening and prostate cancer screening and gene screening and mental health screening, of all those screening tests you talk about, which one would you do yourself? And I hate when they ask that, because, and I said, and I had to think for a second, and I said, well, if I was a young woman and sexually active, I would consider the Pap test. That would be something I think has benefit. Yep. Though I said that 5 years ago, and I'm not sure if it's the same today. And I also said I'd probably consider a colonoscopy when I turn 50. I'm now 54, never had it. Will I? I still think the jury's out. So no. Other questions? Right here. And then there, okay?
Thank you. I'm at the ripe old age of 75, by the way. It was funny to hear that I'm the oldest segment there. 2 weeks ago, I've been told that I needed teeth extracted, and there were 4 quadrants, and I asked to please be given lidocaine, because that was the only thing that I hadn't landed up in an oxygen mask for. Mm-hmm. And he said he was going to give me lidocaine. Then it turned out he gave me carbocaine, and I landed up in the oxygen mask with an arrhythmic heartbeat. And he said it's the same thing. I said, epinephrine I cannot have, because twice before I had already landed up with oxygen mask problem. So they did 7 extractions in one period and gave me carbocaine. And I felt my blood pressure going up. I asked what it was. They wouldn't tell me. Finally, I asked for a mirror, and I put the mirror up so that I could see it in the back. And it was already starting to go down, and it was the higher number was 245. What options? I've been looking for so long for a good dentist that I could rely on, and every time I land up with huge problems. And now I've had the extractions. I'm afraid to go back to him because he lied. He said he gave me a lower number when I asked him finally after the operation.
So can I just interrupt for a second?
Yeah.
I'm not sure why when I come here to speak, people ask me questions about dentistry. Because even though talking about my own kids and orthodontics and that sort of thing is something that I personally experienced, I don't actually know the research in dentistry very well. So I actually don't know the benefits of lidocaine versus other things. And I'm not sure why you needed your teeth extracted, but I don't think I can help you there.
Okay, thank you. Sorry for the interruption.
Right here.
I just had a comment. A while back, I seen a documentary from Michael Moore. I thought it was very, very interesting. It's called Sicko, and I don't know if you've seen it or what, but he compared the Canadian healthcare with the United States, and then pharma, how much they cost here, a drug cost here, $175. You can go to Cuba and get it for $5 and all that stuff. And I just wanted to know if you had any comments, because I think that movie was that documentary was very, very interesting on that. I just want to know your comments.
Yeah, it was highly criticized by Canadians, by the way. When I say Canadians, because I work in healthcare research, and the Canadians that I know, other health researchers say, Michael Moore was not completely fair about, the problems and difficulties in the Canadian healthcare system. I think it's superior to the U.S. in many ways, and mostly because whenever you get sick, you never have to worry about who's going to pay for it. I had a hip surgery 2 years ago, and I never saw a bill. Well, you do have to pay for the drugs, but that didn't really affect me because I told my wife not to stop at the pharmacy on the way back from the hospital. So it's a really good question. The issue of drug pricing, though, is something that I think is probably a national and an international scandal. Americans pay the highest drug prices in the world, also have the highest drug consumption in the world. The U.S. makes up about 5% of the world's population, but consumes something like 50% of the world's pharmaceuticals. In many ways, the U.S. consumer, I believe, is being ripped off because the pharmaceutical industry takes a lot of times government-funded research, turns that research into patented products that are increasingly more and more expensive, and then sells them back to the consumer, when in fact the basic science research was funded by you and I, the taxpayer. And so the consumer gets kind of screwed twice. That's a problem, and it happens in other countries. What we've got in Canada and other countries in the world is that we have negotiating power with the pharmaceutical industry. The pharma lobby is so powerful in the US, though, they have essentially prevented government from even negotiating prices. That is for the overall market. Though if you're a veteran and you're getting veterans benefits, then that is probably one of the best healthcare systems in the US, because they can negotiate prices. They can actually do what any shopper would do, is go and compare prices and get good value for their healthcare dollar. So if you had the Veterans Administration take over the entire healthcare system in the US, I think the overall population, the health of the population would rise, and the amount that you're wasting and spending and worrying about healthcare would drop considerably. It would be more like the Canadian system. Yeah. Any other questions? We've got the right here, microphone here, please.
Hi, Lyme disease. Did not hear much, so obviously, recent years that obviously became a serious problem, and diagnosis, treatment, and all of that.
Yeah. I can't speak knowledgeably about Lyme disease, except I know that it's very controversial. In Canada, apparently there's a certain test for Lyme disease that can help diagnose whether you have Lyme disease. Is a condition that's transmitted by wood ticks, right? That you can, the controversy in Canada, anyways, around Lyme disease is the test is not paid for, right? And so if people want the test, they have to get this special test from the U.S. And when I've looked closely into it, this test that's in the reason why the Canadian healthcare system refuses to pay for the test is because they don't believe it's very accurate. They believe that it perhaps overdiagnoses Lyme disease or even underdiagnoses Lyme disease. So it's not specific or sensitive enough to diagnose the disease. Lyme disease is very controversial. There's, I would argue that you should read everything you can about Lyme disease if you're concerned about it, but don't believe everything that you read about Lyme disease, because some of it is probably not true. So, questions? Other questions? I've worn them down. Great.
One quick question. After seeing that the movie, if you had a choice, because the Canadian healthcare and possibly the United States healthcare, and that movie really described both of them in really good detail. And I was wondering, if someone was sick, where would it be more beneficial to pay the high costs here in the United States or move to Canada if they were sick? I'm not sick, but if someone was, knowing the system, what would be your answer to that?
Yeah, it's a good question. I think healthcare dollars should come out of general revenues, tax revenues. We pay higher taxes in Canada. Okay, so if you're okay with paying higher taxes, income taxes mostly, than your friends in the United States, then the healthcare system in Canada is certainly more humane in my terms, just because there's no insurance companies. There's no competition for patients. You don't see ads for disease, well, other than cholesterol and other things, but you don't see drug ads. You're not bombarded with the market. And because the market sees you as a customer, and oftentimes you're a customer because, well, not because, you're a customer and you don't really have to pay for it because you have insurance, And one of my little chapters in my little pink book, I discussed this thing called job lock. Job lock meaning people are locked into their employment because their health care benefits are linked to their employment. This is something I learned when I was studying, and I thought, really? So you can't change jobs? Oh yeah, people in the U.S. change jobs all the time, but you have to, if you're jumping to another job, you have to think about what kind of health benefits come. If you got kids that need braces, for example, you have to think about all these. In Canada, you don't think about any of that. If you want a job in another province, you just get up and move. You don't think about what kind of health care that my new employer is going to get. So I try to think about what does it do to your psyche. And in many ways, this is the land of the free, but you're not that free if you can't move out of a terrible job into a better job if you're going to get worse health care, because that's really important, that your health insurance. So it really, I don't think it's very humane that you get stuck in situations, in employment situations, and maybe even some nasty situations, but you can't move because of the nature of the way the healthcare market works here. So, and by the way, the United States is an outlier, right? So when you take the 22 OECD countries, France, Germany, Belgium, Canada, US, Australia, you take all those countries and you look at sort of the way healthcare is delivered, most countries have a mix of public and private, right? Including the U.S. There's public health care in the U.S. if you're a veteran and if you're on Medicaid and Medicare, those are public. But most countries, the public size of it is much bigger, and the private's like this. Whereas in the U.S., it's the opposite. The private is this big, and the public is a portion of that. So the U.S. is much different than I would say, every other country in the world when it comes to delivering healthcare.